Okay, so for our case study, we did the flu gets complicated. Um, so for the emergency department nursing notes, it says a 65-year-old male arrived to the emergency department with complaints of stabbing chest pain that traveled up his left shoulder and into his neck. The pain is significantly worse when he lays down flat, so he sits up and leans forward. He stated his heart feels like it is racing. He has been short of breath, fatigued, and expressing chest pain that has intensified throughout the day. Patient has a history of being overweight and is a smoker. He stated that he was diagnosed with the flu 8 days prior and has not received the flu vaccine. The provider ordered 12 lead EKGs, collect cardiac enzymes of troponin levels, and creatinine kinase.
His vital signs for temperature was 100.8 degrees Fahrenheit. His pulse was 126 beats per minute, which is weak and 30. His respirations were 24. His blood pressure was 90/65, and his O2 is 90% on room air.
So what pathogens cause the flu? It is an acute respiratory infection that is caused by the influenza virus. 4 types of influenza viruses, type A, B, C, and D. A and B is our seasonal flu that we get. C can cause mild infections, nothing to worry about usually. D affects cattle, not people, also nothing to worry about. The symptoms that are associated with the flu is cough, fever, vomiting, sore throat, muscle and joint pain, runny nose, and headaches. The best way to prevent the flu is to get vaccinated for it. Other ways to prevent the flu include washing our hands regularly, avoid touching your mouth, eyes, and nose, cover your mouth when you cough or sneeze, avoid others who are sick, and stay home if you are feeling sick.
So for the test results for the EKG, it was a concave upwards ST segment elevation and PR segment depression of sinus tachycardia. His troponin was 0.01 and his CK was 105.
So what did the provider initially think was going on with this patient? The provider's initial thought was that the patient had the flu. The EKG test results show that the patient has sinus tachycardia, which means that the heart is beating faster than normal. So the provider will still consider this a correct diagnosis because untreated flu complications can lead to sinus tachycardia. And what might the provider be looking for with a CXR and CBC? So a CBC is a complete blood count, and a blood test can show a provider underlying health conditions or infections, and a CXR is a chest x-ray and shows a provider how well your heart or lungs are working.
So the CXR results indicated bilateral pleural infiltrates and enlarged cardiac silhouette, and the CBC for the white blood cell count was 22 cells by 10th to the 9th.
So the nursing notes state that the provider verified diagnosis of pneumonia, sputum specimen, blood cultures, and IV antibiotic therapy ordered. Provider noticed hypotension, distended neck veins, and muffled heart sounds, coupled with enlarged cardiac silhouette on CXR. Echocardiogram was ordered. The patient was admitted to med-surg floor for further workup and monitoring.
The most common bacterial pathogens that cause secondary respiratory infections following the flu are Streptococcus pneumoniae, Haemophilus influenzae, and Staphylococcus aureus. The condition is called cardiac tamponade when the condition indicates hypotension, muffled heart sounds, and jugular venous distension. And the cardiopulmonary system includes the heart and lungs, and in order for the heart to do its job properly, it needs oxygenated blood to supply both the body and itself. Pneumonia, which is among the deadliest of flu complications, profoundly affects this system. The lungs fill with drainage, severely compromising their ability to send heart nutritious blood. The heart compensates for this by working harder to send blood faster. As a result, fluid begins to fill in the sac around the heart, which squeezes it and reduces its pumping ability. Because the fluid reduces the heart's ability to get oxygenated blood to the rest of the body, we see symptoms of hypotension, which is low blood pressure, muffled heart sounds, and jugular venous distension, which is when the vein on the side of the neck bulges out.
So the results of the echocardiogram was significant pericardial effusion, which is unable to quantify fluid amount given patient habitus.
So for the nursing notes, it says echocardiogram shows significant fluid buildup in the pericardium. Provider notified of results. Emergent OR booked for median pericardiocentesis to relieve the pressure. Preoperative checklist completed, CHG bath completed, and the patient was transported to OR.
And then more nursing notes. Plan for pericardiocentesis is revised. Fluid and pressure buildup is too great for simple needle pericardiocentesis. Transitioning to full thoracotomy to create pericardial window. OR update given to patient's wife in waiting room, and the surgeon and resident collected appropriate consent with witnesses to perform surgical procedure.
Why did the surgeon have to get consent before performing the thoracotomy if they already had consent to the pericardiocentesis? Because they are not the same procedures, so the surgeon must get consent for each and every operation that needs to be done before they can do it. One is much more invasive than the other. The pericardiocentesis is a procedure that removes fluid from the pericardial sac using a needle, whereas a thoracotomy is a surgery procedure that involves making an incision in the chest wall to remove the fluid. Why is a witness needed for surgical consent? There may be multiple reasons for why a witness is needed for surgical consent. Some of the reasons include language barriers, making sure that the surgeon has told the patient accurate and detailed information about the risks, recovery time, surgery details, etc., and to make sure that the patient is the one signing the form and that the patient is conscious enough to sign the form with full understanding about the operation details. What would the surgeon do if they did not have time to get consent? In an emergency situation, the surgeon may not be able to get consent from the patient or their representative. In these situations, a surgeon can start treatment without consent.
So fluid accumulation and thoracotomy concepts. So fluid accumulation occurred when the respiratory pathogen entered into the patient's circulation, reached the heart, and caused severe inflammation. A median thoracotomy can be performed to open the pericardium, drain the fluid, and release the pressure around the heart. Thoracotomy was performed when incision was made in the pericardium. Fluid spurted from the thoracic cavity because the pressure inside was so great. Note the fluid pooling around the heart after the pericardium has been opened.
The type of fluid that was built up in the patient's pericardium is called exudate because of its high white blood cell count. As stated previously in the case study, fluid accumulation occurred when the respiratory pathogen entered into the patient's circulation, reached the heart, and caused severe inflammation. When the pathogen entered the heart, neutrophils, macrophages, monocytes, and polymorphonuclear cells were transported to destroy bacteria. These cells are called inflammatory cells. The fluid that begins to build up as a result of the inflammation, known as exudate, contains dead and dying bacteria, inflammatory cells, and cell debris.
Our diagram here shows a study of acute pericarditis cases noted a winter increase in case frequency.
So for microbiology concepts, when influenza cases are most prominent in the US is during December through February. Influenza activity usually starts becoming more prevalent in October and can last as late as May. And there isn't a specific correlation with the timing of pericarditis cases with the seasons, but they sometimes can correlate with the seasons. If someone has had recent injuries or surgeries, or if the person has an autoimmune disorder, or if there's an outbreak of an infection that can lead to pericarditis.
More nursing notes. The patient was transferred back to original unit after recovering in PACU. Pericardial fluid sent to lab for culture and sensitivities testing. Patient started on IV rosifin, vancomycin, and doxycycline.
Why is the provider treating the patient with multiple antibiotics before they know what is causing the infection? This is happening because antibiotics are the main treatment for infections. Also, the patient is becoming resistant for certain antibiotics that are being used, along with some will just not work due to the type of infection the patient has. It is important to start antibiotic therapy treatment as soon as possible when it is known that there is an infection present. This therapy is called combination antibiotic therapy. Some benefits to this is that it can using multiple antibiotics can enhance the performance of each other, and it is more effective than just using one antibiotic and decreases the chances of resistance. Drawbacks are if the antibiotic resistance occurs, it will be much harder to treat the infection, and this process is very expensive.
So, what correlation can you make between the patient's emergency surgical situation and his initial infection? Correlations I can make between the patient's emergency surgical situation and his initial infection is hypotension. Also, the chest pain that the patient was experiencing correlates to the fluid buildup that was pushing on his heart. His head was working overtime, ensuring that there was enough blood supply, although there wasn't due to the pressure which caused hypotension. The pain will subside after the surgery due to the release of pressure that was constantly on the heart when they were sick. Anything else we want to discuss with the patient about avoiding these infections in the future would be to try to stop smoking altogether or significantly reduce the amount you are smoking a day. Get your vaccination for the flu, and if you get symptoms again, do not wait 8 days to come in. It is important that you come in right away.